Good afternoon, ladies and gentlemen, and thank you for waiting. All lines have been placed on listen-only mode, and the floor will be open for your questions and comments following the presentation. Without further ado, it is my pleasure to turn the floor over to your host, Ms. Peggy Ullman. Ms. Ullman, the floor is yours.
Great. Thank you very much, Wes. Welcome, everybody, to our webinar today. We are talking about meeting deadlines for 2015 PQRS and meaningful use, as well as getting an update on the 2016 Medicare physician fee schedule. I want to very briefly discuss those of you who know us. We are VHQC. We are the Quality Improvement Organization for Maryland and Virginia. We also have served as the Health IT Regional Extension Center for Virginia. For those of you that are in Maryland, that means we perform a very similar role to what CRISP does in Maryland. And we provide education to providers and hospitals on PQRS, meaningful use, and the value modifier. Here are your contacts. If you are a Maryland-based physician provider, you can contact me. If you are a Virginia-based physician provider, you can contact Kelly Lunello. And if you are a Maryland or Virginia-based hospital and you have questions, you can contact Sandy Gaskins. We are very pleased today to have two speakers from CMS. We have Dr. Barbara Connors, who is the Chief Medical Officer of Region 3 of the CMS in the Philadelphia Regional Office. Dr. Connors is board certified by the American Board of Internal Medicine and the American Board of Preventive Medicine. We also have Patrick Hamilton, who is a health insurance specialist with the Centers for Medicare and Medicaid Services in Philadelphia. He has worked in the area of provider outreach for the past 13 years and has served the states of Delaware, Maryland, Pennsylvania, Virginia, West Virginia, and the District of Columbia. So there is a lot of content in this presentation, and so I am very happy to turn it over to Patrick and to Dr. Connors to discuss meaningful use and PQRS in 2016.
Thanks, Peggy. I'm very happy and excited to be on the call today. We are in the midst of a lot of exciting changes that are coming about in the Medicare program. We're going to start by talking about some important upcoming dates that are coming up in terms of, hold on for 1 second. Just want to make sure we can advance the slide. Okay. We're going to talk about some upcoming dates for what you need to do if you still have not submitted information or data for PQRS and also for your attestation for meaningful use for 2015. There are some deadlines that you need to be aware of, and we'll talk about what options are still available to you for those programs. We're going to spend a lot of our time talking about what's coming up in 2016. This is a very critical year in the Medicare program. Hopefully you've been paying attention to the macro legislation that was passed last April and the impending MIPS and APM incentive programs that are beginning in 2019. This is going to be a transition year, and we'll talk about that. We're also going to talk, even though we're going to be focusing on macro this year, there are still things that you need to be aware of and information that you need to have as it relates to the incentive programs, the quality reporting programs as they exist today. So we'll be talking about the updates to PQRS, to the value-based payment modifier, and the meaningful use for 2016. So in terms of the upcoming dates, the dates that are listed on this slide, these are deadlines for your 2015 participation in the various programs, and these mainly are for PQRS and for meaningful use. So January 1st began the reporting period for PQRS. 2016 is the performance year to determine whether or not you will be assessed for a payment adjustment in 2018 for not successfully reporting PQRS. It's a full calendar year participation, just as it's been in previous years. Also, the reporting program for 2016 meaningful use is a full calendar year in 2016, so it runs from January 1st through December 31st, and those are for all EPs, eligible hospitals, and critical access hospitals. And I'll talk about the changes for the performance period when we talk about meaningful use. But it's the full calendar year for 2016 if you are a returning player, if you've already accepted to meaningful use. If 2016 is your first year for meaningful use, then you have a 90-day reporting period, and we'll talk about that. To attest for meaningful use for 2015, the attestation opened on January 4th and it closes on February 29th. So you have between January 4th and February 29th to attest and to submit your clinical quality measures. We still are affording you the opportunity to submit your quality measures for both PQRS and EHR if you're using an EHR system or a data submission vendor and get credit for both programs. If you have registered for the GPRO, for the Group Practice Reporting Option for PQRS, and again, you must have registered with CMS as a group by June 30th of last year. So if you are still one of those providers, or if you're an administrator and you're trying to figure out what can I do, how can I attest to how can I submit data for 2015 for PQRS, the Group Practice Reporting Option, the GPRO option, is off the table if you haven't submitted or if you haven't registered with CMS by last June. So if you have not done that, then the only option that you'll have at this point would be to submit data for your individual EPs. And at this point, if you haven't done any, if you weren't using the claim submission or if you don't have your EHR set up, the options that would be available to you would either be a qualified registry or a qualified clinical data registry, QCDR. My acronyms are starting to get confused. So either a qualified registry or a QCDR, you would have to find one that would still be able to accept you as a provider with their registry, and you would have to adhere to their deadlines. CMS imposes deadlines on both the registries and the QCDRs as to when they have to submit their data, your data, to us. The registries, in turn, when you enter into the contract with the registry, will say, we have to submit our data by, when is it, February 29th, I believe it is. February 29th. No, I'm sorry, it's March 31st. March 31st is when the registries have to give their data to CMS. So they may say, you have to give it to us by, let's say, February 15th so that they can process it, format it properly, and submit it within the time frames. So if you have to avail yourself of a registry or a QCDR, make sure that, number one, they still can take you on, because it is, getting a little bit late in the game, and also make sure that you are going to meet the deadlines that they set up in your contract, because you will enter into a contract agreement with the registry. If you did register for the Group Practice Reporting Option and you're going to be using the web interface, then you can start your data submission now. We opened up the submission on January 18th, and you have until March 11th in order to submit information via the GPRO web interface. And then February 29th is the last day for CQMs, for meaningful use, and for PQRS. If you're going to report them and get credit for both programs, you have to meet the meaningful use attestation deadline, which is February 29th. So that is an important deadline to meet. I'm also going to talk about the hardship exception application deadline that is upcoming. We'll talk about that in the meaningful use portion of the webinar and give a little bit more detail about that. We're also going to hold off all questions until the end. So as you have questions, if you just want to jot them down, you can also use the chat feature. We'll be taking questions at the end. So as I mentioned, the macro legislation is the Medicare Access and Chip Reauthorization Act. It was passed last April. It was a pretty big deal because it got very wide-range bipartisan support. It was probably the biggest piece of legislation that was passed that actually had true bipartisan support. There was a lot of support for this law. The big headline with macro was that it finally repealed the SGR, or the sustainable growth rate, which always prompted those doc fixes, which became an annual conundrum for Medicare and for lawmakers. That's when you would hear at the end of every fiscal year, if we don't implement the stock fix, there's going to be a 21 cut to physician payment. And then at the last minute, every year with the exception of 1 year in the early 2000s, Congress would have to implement a Band-Aid and prevent the cuts from going through. So MACRA got rid of that. It implements small increases to the physician fee schedule over the first couple of years. But the bigger story, and what you're probably going to be, if you're not already interested about this, you will become very interested about this. It sunsets, or it basically ends the three quality programs as they exist today. So PQRS, value modifier, and meaningful use. The payment adjustments will sunset for those individual programs as of December 31st, 2018, in advance of the new merit-based incentive payment system and alternate payment models. So these are two acronyms that will become part of your daily lives called MIPS and APM. So I'm going to give a very, very 50,000-foot high-level overview of MIPS and APM. We have proposed rules that are going to spell out how these programs are going to be implemented this spring. I will very strongly encourage you, once they are out, to read them, offer comments. We are really engaging the provider community to get your feedback and your input on these programs as we develop them. There's a lot of behind-the-scenes work that's going on with external partners to get these programs right. The information that's included in this presentation is what was given to CMS in the legislation. So this is the parameters that were spelled out by Congress when the law was passed. So as I mentioned, it sunsets the individual payment adjustments for these programs. The MIPS program and the APM start January 1st of 2019, and an EP will have the choice of either participating in an alternate payment model, and I'll explain what those look like in a second, or if they cannot participate in an APM, then they would become eligible for the MIPS program. The MIPS program, the incentive can either be a positive, a neutral, or a downward adjustment, just as it is with the value modifier. And with the APMs, their incentive structure is a little bit different. They can get a 5% incentive payment for 6 years if they meet the requirements of the individual program that they are in. Now, to whom does this apply? It will start for the first 2 years in 2019 and 2020 for all physicians, physician assistants, certified registered nurse anesthetists, nurse practitioners, and clinical nurse specialists. Those 5 provider types, the physicians and the 4 that I mentioned, are also the 5 provider types for whom the value modifier will be in effect in 2018, or will be applied to in 2018 based on 2016 performance. And that's why we're going to spend a lot of time on the value modifier as it pertains to these new provider types. In 2021 and onward, the Secretary will give CMS the authority to add provider types. So your audiologists, your speech pathologists, your midwives, those other EPs who aren't included on this slide and aren't brought in from the beginning will most likely be incorporated into the program starting in 2021. Now, those who are excluded from MIPS are those who are qualifying APM participants. So if you are in an APM, then you will not be subject to MIPS adjustments. You can also be a partially qualifying APM participant, and we'll go into some detail once the rule is released in the spring about how that works. And there's also the law allows for low volume threshold exclusions. They haven't been spelled out yet, but the law gives CMS the authority to establish that. So what is MIPS? What are we going to be looking at? Well, we are, as I mentioned, sunsetting the individual quality reporting programs, but there are going to be facets of each of those programs incorporated into this new system. So you can see on this table, starting in 2019 and going through 2020, there are 4 main categories. Quality measures, which is kind of akin to PQRS, so it's not going to be PQRS as you know it today. Resource use, which is related to the value modifier. Clinical improvement activities, and that is a new category for which we haven't specifically incentivized or instituted payment adjustments on. And then meaningful use of certified EHR technology. And we are working on exactly how the integration of EHR technology will be incorporated into the MIPS program. There will be changes to that as well. Now, the percentages that you see here are the percentage of each of the categories weighted to come up with your MIPS score. Your MIPS score will be from a 0 to 100 range, and based on where you fall on that 0 to 100 scale, there's going to be performance thresholds above which you could get certain upward adjustments, below which you would get payment adjustments downward. And you can see that the adjustment factors will be a positive or minus 4% in the first year, and it goes all the way up to 9% upward or downward starting in 2022. And there is the opportunity for providers to earn up to 3 times those adjustment factors for exceptionally well performance. So in 2022, for someone who is exceptionally high and passes the highest threshold, you could get up to a 27% incentive payment upward adjustment. So there is a real opportunity to earn incentives with this new program. With APMs, as I mentioned, it's a little bit different in that it is a flat 5% incentive payment for 6 years. Now, what someone needs to do, an EP needs to be in a certain advanced payment model that is eligible for the program. Now, the types of models that we are thinking of are things that are coming out of the CMS Innovation Center. So things like Pioneer ACOs, bundled payments, those types of programs. And when the rule comes out in the springtime, there's going to be very specific criteria that an APM would have to meet in order to be called what we say an eligible APM in order to receive these incentive payments. Now, the APMs to be eligible, they have certain criteria that are already spelled out in the law, in that they must make payments based on follower reporting similar to what is called for in MIPS. They must require participants to use certified EHR technology, and there also has to be some type of financial risk that is part of the setup of the APM. And again, once that final rule or the proposed rule is out, we will be able to spell out specifics about how somebody can become a qualifying participant or a QP in an eligible APM in the program to receive this. And then we'll also be able to go into more detail in terms of, if I am in an APM, then how can I be assured that I will not be subject to any of the MIPS adjustments? So more on that in the springtime. Once you see that, I really encourage you to avail yourself of any opportunity you have to listen to training sessions such as this. Get in touch with your medical societies. We'll be partnering with them as well to make sure that you are all very well informed. All right, so let's turn to PQRS for 2016. Excuse me. In terms of the criteria for reporting in 2016, there really weren't many changes. So I'm actually going to go through a lot of these slides because the reporting that you did in 2015, the same criteria holds true for 2016. So I have a lot of decision trees, and I'm just going to go through them, but they're really there for your reference. There are 281 measures in PQRS, 18 measures on the Eeprom Web Interface, 23 cross-cutting measures, and we add and subtract measures every year in the Medicare Physician Fee Schedule final rule. So that's nothing that's new. If you have certain measures that you reported on in years past, I would just check the list to make sure that they're still available. There are 3 new measures groups. If you are in a practice that avails yourself of the opportunity to report on a measures group, we have a couple of new measures groups that are included. The big change really for PQRS reporting, the Qualified Clinical Data Registry, or the QCDR, was a new option that was instituted 2 years ago. Was it last year? I think it was last year. It was only available for individual EPs who were not reporting as a group. This year, the macro legislation that I just talked about allows for QCDRs to be used by groups. So if you are going to be registering with CMS to do the group practice reporting option, or GPRO, you can use the QCDR option for reporting. So, again, I'm just going to go through these decision trees because the criteria are not changing. So if you're reporting through claims, then you report 9 measures covering at least 3 domains. If you can't find 9 measures to cover the 3 domains, then you can report on fewer measures or from fewer domains. You just be subject to the validation process. If you see 1 Medicare patient in a face-to-face encounter, you have to report at least 1 cross-cutting measure, and you have to report for at least 50% of your Medicare fee-for-service Part B patients. So that has not changed. The same criteria as last year. The same thing with registries. I mentioned the registries a little bit earlier. The only difference with registries are that if you are going to report on individual measures, then either individual EPs reporting a solo or group can do so, can use the registry to report on individual measures. With those measure groups that I talked about, only individual EPs can use a registry to report on measures groups. and that hasn't changed either. That's always been part of the program. That's the only big difference is that if you're going to register as a GPRO, as a group, you're going to use a registry. You just can't choose the measures groups. Last year, CMS put together some specialty measure sets that gave providers of certain specialties some help in finding measures that pertain to their scope of practice. There were 12 that were put up last year. We added another 5 this year. So there's a total of 17. These are in no way required, so we don't say, listen, if you're a radiologist, then you have to do these measures. These are just suggestions so that you can report the greatest number of measures and not, miss the criteria. If you're using your EHR or a data submission vendor, it's the same requirement as last year, 9 measures from 3 domains. If your system does not have patient data for at least 9 domains, then you report on the measures for which you have Medicare patient data. And an EP must report at least 1 measure that has Medicare patient data. We understand that your systems don't have just your Medicare patients, but you have to have 1 measure, at least 1 measure, that has Medicare patient data with it. The QCDRs, the difference between the qualified registries and the qualified clinical data registries is that we are allowing measures that are not necessarily or haven't been created specifically for PQRS, but are part of the QCDR to be included in the analysis of your quality reporting data. So if you have other entities for which you are doing reporting and you want to use a QCDR, CMS is allowing that, so you'll see you will be reporting both individual PQRS measures and non-PQRS measures that have been approved by CMS for the particular QCDR. I mentioned the GPRO Web Interface. This is an option, and again, this is not changing for groups that have 25 or more EPs in the practice. There was a slight change last year in that we standardized or we made consistent across the board in terms of group sizes the number of assigned beneficiaries that had to be included in the sample size. In years past, depending on the size of the group, you may have had to include more beneficiaries. But we settled on 248 last year for your sample, and that is what we are going with in 2016 as well. Now, for groups that have 100 or more EPs, they are required to submit the CAPS for PQRS survey. And the CAPS for PQRS survey basically is a 12-point survey filled out by patients, which basically gives feedback on the quality of care that they received in the office setting. So starting in 2015, the CAPS survey was required or was mandatory for groups of 100 or more EPs. We were thinking about expanding that requirement for groups of smaller sizes, but we opted against that. So in 2016, it is still required for all groups of 100 or more EPs. Now, we do understand that there will be some groups that meet the size requirements that have 100 or more EPs, but they may not have enough beneficiaries in order to administer the survey. And if that's the case, then you would be exempt from it. And CMS will notify you if you are exempt from the PQRS survey. But if you have more than 100 EPs, then it is required. So you would submit the survey, the 12-point survey, and then you also have to submit one of the 4 other reporting options, but the reporting criteria are slightly different. And by the way, if you're a group of less than 100 EPs and you administer this survey, it's not mandatory, it's optional. You can still submit your data through this option. So it would be the survey plus submitting data through the qualified registry, but it would only be 6 additional measures covering at least 2 domains. It would be measures that are not included in that survey. If you're doing the GPRO Web Interface, you have to do all of the measures. I believe there are 18. So you'll be doing the survey plus everything that's on the web interface. If you're going to use your EHR product, then it's 6 additional measures covering at least 2 domains. And the same thing for the QCDR. It would be 6 additional measures covering at least 2 of the domains. All right, moving on to the value modifier. And this is where it gets a little complicated this year, in that we are expanding the provider types to whom the value modifier will be applied. And as I mentioned with the macro legislation, macro specifically called for physician assistants, nurse practitioners, clinical nurse specialists, and CRNAs to be included in these first 2 years of macro implementation for MIPS. CMS originally had proposed that all non-physician practitioner types, so not just the 4 that we're going to be talking about, but also the pathologist, the speech-language pathologist, the audiologist, and then originally everybody was going to be brought under the value modifier fold, and quite frankly, on our end, it would have been an easier way to implement the policies, but because we wanted to have consistency in terms of pinpointing these 4 non-physician practitioners that were identified in macro, CMS decided that we were going to just incorporate those practitioner types for 2016. Actually, for the 2018 value modifier, but it's based on your performance this year in 2016, the 2-year look-back period. Quality tiering is going to be mandatory. We will be able to figure out exactly which groups will be subject to quality tiering and also the amount of the payment adjustments upward or downward for those particular groups. And I'm going to do my best to go through and walk you through the process of how you can determine whether or not you will be assessed the value modifier if you're one of those non-physician types, the amount of the value modifier, and what happens if you don't do your PQRS. And again, 2018 is the final year for the value modifier in anticipation of MIPS. Now, in terms of the quality measures and the cost measures, they have not changed either. So the quality measures that we're looking at are PQRS data that's submitted either by individual EPs or through the group if they register through the GPRO option, and also outcome measures that we look at through claims analysis. And these are the same outcome measures that have been used for the past couple of years. So all-cause hospital readmissions, composite preventable hospitalization for acute conditions and chronic conditions. That means that CMS will analyze claims on our end. It does not mean that you have to submit any additional information or quality data other than your PQRS stuff. So if you haven't been involved with the value modifier and you're hearing this for the first time, do not fret. You do not have to submit anything additionally from your PQRS information. And then also, if you are one of those groups that will be doing that patient survey that I mentioned, the CAS survey, you can also submit that, and that will be brought into the calculation of your quality measures. The cost measures are also the same this year, and this is all done by analysis on CMS's end, so you do not have to submit anything for cost measures. The things that we were looking at are on the slide: total per capita cost, total per capita cost for 4 specific conditions that are listed here, Medicare spending per beneficiary for 3 days before and 30 days after a Medicare patient is in the hospital. And then we standardize and risk adjust them to make up for or to address the specialty mix of EPs in a particular group. And if you're interested in the calculus of how that is done, there is more information than you probably want to see on the CMS website. I'll be happy to share that with you. Okay, so this is where it gets interesting. This is where I'm going to do my best to try to explain how the adjustment is going to be applied and to whom and how we figure that out. And the crux to understanding this are really two things, really 3 things. Are you a physician assistant, a nurse practitioner, a CRNA, or a CNS, clinical nurse specialist? And for purposes of our discussion, I'm going to say physician and the 4 non-physician types, because we also have to talk about the non-physicians who aren't PAs, NPs, CRNAs. So I'm going to try to make this as clear as possible. You also have to say, am I solo or am I part of a group? Solo is a little bit easier to understand. If you're part of a group, then the question becomes, are there physicians in my group? Okay, a lot of questions, and I'm going to try to walk you through. So this first table, and I guess I should back up and say that the value modifier, because we did have an audience last week who still haven't heard the value modifier. I'm sure it's nobody on this phone because I know that you're all very well-read on this topic. But the value modifier, just as a very high-level overview, is a composite of both quality and cost, the two things I showed you on the slide. There is scoring that's involved, and you come up with a score, and you fall into a scatter plot of sorts that put you into one of 9 categories. And the 9 categories are either low quality, average quality, high quality, low cost, average cost, high cost. And depending on how you fare with your score would fall into one of these 9 boxes. And based on the box that you fall in, that determines what your value modifier is for 2018. And it is an adjustment that is done per claim for Medicare Part B services that are billed to the physician fee schedule. So it's in addition to any upward or downward adjustment or any downward adjustment that you might be getting for PQRS, because we don't have incentives anymore, and also any adjustments you might be getting for meaningful use. So 2018, I mean, it's getting up where the physician can get up to 9% of their payments cut if they're not participating in these programs this year. So even though we're talking about MIPS moving into APMs, it's still critically important that your docs and your non-physician practitioners are all still doing their reporting because they still are, the law calls for these payment adjustments to be implemented in 2016, 2017, 2018, and then we move into MIPS. Okay. So this first table talks about groups that have 10 or more EPs. And when we determine the size of the group, when we say 10 or more EPs, that is all eligible professional types. So it's your physicians, it's the 4 that we're talking about, and it's everybody else. That's how we determine the size of the group, because the size of the group determines the size of the adjustment upward or downward. So this first table talks about groups that have 10 or more EPs. So they are physicians and the 4 provider types here that are in groups of 10 or more, and within those groups, there are physicians. And I'll explain why it's important to make that distinction when we go to the next few tables. So here we're talking about groups of 10 or more EPs that have physicians in the group. And as you can see, the downward adjustment, if they have low quality at high cost, is 4%. And this is based on quality tiering. So you report PQRS data, you're successful, you avoid your PQRS adjustment, and then you go into quality tiering for value modifier. So let's say that you happen to fare poorly on the quality and cost score, then it would be a 4% payment reduction. On the flip side, if you do exceptionally well and you have high quality at low cost, then you get an upward adjustment of a factor of 4.0. Now, the 4.0x means that this is all budget neutral. So the law specifically states what the amount of the downward adjustment is. It's a percentage of payment. So for a given year, we will know how much money is in the bucket for the adjustments that we're taking for poor performance. We take that money and then we bring it over to the groups that perform well. We do a little bit of algebra, we solve for X, and that's how we determine what the adjustment is going to be. So it's anywhere from a 4% downward adjustment to an upward adjustment of a factor of 4.0. And again, these are for groups of 10 or more EPs that have physicians in the group. Going to the next slide. The next table talks about groups that have 2 to 9 EPs. So 2 to 9 EPs in the group. There are physicians in the group, just like the last time, or you are a physician solo practitioner. We're going to talk about the solo PAs, NPs, CNSs, and CRNAs on the next slide. So for this one, groups of 2 to 9 EPs, there are physicians in the group, or you are a solo physician. It's the same quality and cost scoring mechanism. That does not change based on it. The only thing that changes is the size of the adjustment upward or downward based on the group setup. And as you can see, it's anywhere from a negative 2% downward adjustment to an upward adjustment of 2.0x. Again, this is for the groups that are smaller, 2 to 9 EPs. There's physician in the group, or you are a solo physician. The reason why we broke it down this way is that the groups that we talked about on the first table, they were the first groups that were brought into the value modifier starting in 2015 based on their reporting in 2013. So they've had a couple of years to get used to this and being subjected to the quality tiering. For these groups, they were brought in later in the program. So they were actually held harmless the first year, meaning so long as they reported their PQRS, the quality tiering, and you'll see what I mean by hold harmless in the next slide. And then for the first year that they were subject to quality tiering for which they could get a downward adjustment, they were subject to these numbers here. CMS made the decision to hold the 2015 amounts for 2016, so these did not change for these groups. The last table. So now we are going to talk about the solo PAs, NPs, CNAs, CNSs, and CRNAs. So if you are a solo physician assistant nurse practitioner, clinical nurse specialist, or CRNA, then you're solo. Or if you are in one of those four types that are in a group of any size that has no physicians. So we're talking about the four provider types that are either solo or they are in a group of any size and there are no physicians in the group. These folks are held harmless from any downward adjustment for poor performance. So that means so long as you are doing your PQRS reporting, you will avoid the quality tiering downward adjustment. So you see that low quality, it's all zeros. And that's just, that's for 2016. That would be for 2018 based on your 2016 performance. Now the caveat is, I keep saying so long as you do your PQRS reporting. If you forego PQRS, you don't have to worry about quality tiering because you're automatically getting a 2% cut for these groups, and for those who are on the first table that I mentioned, it's an automatic 4% cut. You don't have to worry about quality tiering, and that's in addition to the 2% PQRS adjustment. And I know that's nobody on this phone because I know you're all very well read and participating, and I know I don't have to, belabor that point, but it bears mentioning that so long as you are doing your PQRS reporting, you avoid those automatic cuts. And then for these groups, they are held harmless to human adjustment downward based on that quality tiering. All right, very complicated stuff, I understand, so we try to come up with two decision trees that hopefully will help you walk you through this. If you were looking at this slide, if you printed it out, I'm assuming that you got copies of this presentation. If you haven't, you will. If you look at these slides with all the arrows, it looks very confusing. So if you have the opportunity to view these slides in PowerPoint and do it through the slideshow with the animation, I think it helps to understand the information a little bit more clearly. Excuse me. All right, so how does participating in PQRS this year affect the value modifier in 2018? So the question that you have to ask yourself, do I plan to satisfactorily report for PQRS in 2016? And if you don't, then as I mentioned, you don't have to worry about quality tiering. You're automatically going to get that downward adjustment. But let me explain how it will be applied, hopefully a little bit more clearly. You have to ask if you're a physician or one of the four provider types that we're talking about. And if you are not a physician or one of those provider types, meaning you're an audiologist, a speech-language pathologist, et cetera, then since you're not doing PQRS, you will be subject to the PQRS penalty, but the value modifier doesn't apply to you because you're not one of those five provider types. However, if you are one of those provider types, and again I said, one of the crux of how it's going to be applied is whether or not you are a solo or part of a group. If you are solo and you're not reporting PQRS and you're one of these provider types, then you're going to be subject to the automatic value modifier downward adjustment of 2%, and you're going to be subject to the 2% PQRS payment adjustment. If you're part of a group, remember I said you have to say, well, are there physicians in the group? Because that determines the size of the adjustment. And if there are non-physicians in the group, so no physicians in the group, then the same penalties would apply. Because you are a physician, a PA, NP, CNS, or CRNA, you're you're in a group, but there's no physicians in the group. So you get the automatic value modifier downward adjustment, and you get the PQRS payment adjustment. If there are physicians in the group, remember we had two tables based on the size of the group. So for those that are in the smaller groups, 2 to 9 EPs, again, the same payment adjustments will go into effect for you. If you are in the group that has 10 or more EPs, you'll remember from the first table, it's the 2% PQRS payment adjustment and the 4% automatic payment adjustment for the value modifier. And again, this is because you are not reporting PQRS. This has nothing to do with quality tiering. Quality tiering is this table. So if you are going to do PQRS, and I'm sure that's everybody on the phone, then we would ask, are you a physician, PA, NP, CNS, or CRNA? If not, if you're not one of those provider types, but you are doing PQRS, then you avoid the PQRS payment adjustment. And again, the value modifier doesn't apply to you. If you are one of those provider types and you are doing PQRS, and we're hopefully getting into the situation that everybody on the phone will be in, then we ask the same question. Are you a solo practitioner or part of a group? If you're solo, then we have to ask if you're a physician. Because if you're a physician and you're doing PQRS, then you avoid the payment adjustment for PQRS. But solo physicians, for quality tiering purposes, could be subject to upward, neutral, or downward value modifier adjustment. And again, that was the second table that we talked about, so that's anywhere from a 2% downward adjustment to an upward of 2.0. Solo physician. If you are a solo PA, NP, CNS, or CRNA, then you avoid the PQRS payment adjustment, but you only would be subject to upward or neutral. So it was that table that had the zeros in the first column, because again, you're held harmless from downward adjustment for poor performance this year. Again, solo PAs, NPs, CMSs, or CRNAs who are reporting PQRS. If you are in a group, now group means one of two things. Either you registered with CMS to do the GPRO reporting option, or you meet the 50% threshold, which means at least 50% of your individual EPs under the tax identification number of the group successfully report for PQRS. So we get into the whole business again about determining whether or not there are physicians or not in the group. And if there are no physicians in the group, then again, they would avoid the PQRS payment adjustment, and they also would be subject to just the upward or neutral value modifier, that third table that we looked at. If there are physicians in the group, again, we have to determine the size of the group to determine the size of the adjustment. So for the 2 to 9 EPs, they would be subject to either the upward, downward, or neutral adjustment for value modifier. So they would be in that second table that we looked at. And then for the groups of 10 or more EPs, I'm sure you probably know by now, it's a 4% or an upward 4.0x upward adjustment. Hopefully that makes it a little bit more clear. If you, like I said, if you're going to be looking at this electronically, definitely go through it in the animation pane. These are just some actions. You can review these. I want to try to get to questions as quickly as possible. I have a couple of things I want to talk about specifically for meaningful use. You've probably heard that we restructured Stage 2 for meaningful use last year in a modifications rule that also spelled out what Stage 3 is going to look at. You also need to be aware of the fact that there's been a lot of talk about what meaningful use is going to be moving forward. There were some comments that were made by the administrator at a conference last, or I guess it was 2 or 3 weeks ago now. As it stands right now, anything that you may have heard about what meaningful use is going to be really relates to how it's going to be integrated into the MIPS program that I talked about earlier. So meaningful use, the new Stage 2 or modified Stage 2 or however you want to refer to it, it's still on the books this year. So it's very important that you pay attention to the changes for 2016. When the rule came out last year, We made some specific changes for 2015. We made some specific changes for 2016 and for 2017. So what I want to do is just to highlight the specific changes for 2016. There's now only 10 objectives for EPs. We cut a lot of stuff that was either duplicative or just we weren't getting information that was any real value to CMS, and it was becoming overly burdensome for providers to report. So we have, restructured. And what this means is that, in 2016, everybody is now reporting on the same set of measures. So you may very well be in a practice where some of your docs are reporting on stage 1 and some are on stage 2. That dichotomy is no longer in place. So everyone's reporting on the same measures. There are certain exceptions or exemptions for docs that would have been in stage 1 at certain points, and we can go into detail offline if you need specific information about that. The hospital reporting period is now going to be based on the calendar year. I'm going to go into detail about some changes about the patient engagement or the patient action measures that it would be good news to you if you've not heard it already. And then reporting on CQMs have not changed. So you still are going to report CQMs the way that you've done either through attestation or directly through your system and align it with PQRS. I mentioned the reporting period for 2016, January 1st to December 31st. Anyone who is new to the program gets a 90-day reporting program. And for 2016, anyone who should have been or was scheduled to be in stage 1 this year, which means that you would have started the program last year or you would be starting this year. There are alternate exclusions for a couple of the measures as it relates to CPOE. I usually put slides in here that give you all of the measures and the exceptions and the thresholds and whatnot, but I took it out because it was very cumbersome. But if you need information about specific measures, you can contact me offline. The two that are most important that you're probably going to be most excited about: patient electronic access. That was that pesky patients have to go in and view, download, and transmit to a third party their information. Getting people to either go online, go to a portal, making them responsible for actually doing something, and also secure messaging. So not only going onto the system and looking at their data, but actually communicating with their provider of care using that system. The original threshold was 5% for anyone who is in stage 2 starting in 2014. The modification rule made it much easier in 2016 to meet even easier in 2015. But for 2016, the requirement is that instead of 5%, just one patient has to do the view, download, or transmit, and just one patient, or has to be the same patient, has to use the secure messaging feature in the portal. So we're going from 5% to just one patient this year. As it stands right now for 2017, the requirement is back up to the 5% threshold, but that could be subject to change based on what comes out in the MIPS proposed rule in the springtime. If you are participating in Medicaid meaningful use, or if you are happen to be part of a hospital doing a hospital program, that meaningful use program is continuing. So when we're talking about MIPS and the changes that are taking place, it is Medicare meaningful use for individual EPs. The hospital program and the Medicaid program are remaining intact. Quickly, hardship exceptions, a lot of information coming out about this. There was a law that was passed, the Patient Access and Medicare Protection Act, at the end of December, which allows CMS some flexibility for hardship exception. A lot of misinformation about this, a lot of misinterpretation. There was stuff that went out. People thought that CMS was just going to do blanket exemptions and that no one had to do meaningful use in 2016. That's not the case. The requirements of the program are still intact. The payment adjustments that you would be receiving now in 2016, that started January 1st, were for non-performance in 2014. So the payment adjustments and the process to contest or appeal those payment adjustments, that's all been done. The 2016 payment adjustments are intact. We're talking about the 2017 payment adjustments for failing to attest to meaningful use successfully in 2015. It does not gives CMS the authority just to waive the requirements. What it does is it allows us to look at groups of providers. It really is what it's doing is streamlining the application process so that if you were in a practice with 50 docs, you don't have to fill out 50 requests as you did before. You can submit that as a group of physicians or a group practice. So that's basically what the information is doing. We are looking at a couple of categories such as release of the rule, and if there was a hardship that was met because of the timing of the release of the rule. EHR vendor issues, are still a very big problem with meeting meaningful use attestation deadlines. Do not think that what came out at the end of December means you do not have to do meaningful use. Coupled with what the administrator said, there's a lot of information. You still are on the hook for doing meaningful use this year. This just gives us a little bit more leeway to process applications for the 2017 payment adjustment. So the deadline to attest for meaningful use is February 29th. You will know whether or not at the time, if you met attestation requirements, if you met all the requirements, and then you have until March 15th to get the application in for that payment adjustment. Because again, your 2015 performance will determine the 2017 payment adjustment. Slide 39 basically tells you who does not have to submit the hardship exceptions, and these are not new. These are the automatic exceptions that have been part of the process. So if you're new to the program, newly practicing rather, if you are an eligible professional with anesthesiology, diagnostic radiology, interventional radiology, nuclear medicine, or pathology specialty codes, and again, it's all based on whether or not that specialty code is included in your PACOS enrollment information, and if you're hospital-based or if you're newly practicing. These are the resources for all the programs that we talked about. Please avail yourselves of them. A lot of information is on the CMS website, and there is our contact information. I'm assuming, Peggy, that everybody is going to have a copy of this presentation, so I'm going to move to your last two slides, but I just want to make sure that everyone has our contact information if we need it.
Yes, we will be sending out the slides after the presentation, and I can give people my email address. It's poehlmann@vhqc.org. And if we have about 7 minutes left, so let's see how many questions we can fit in, and then we also encourage people to put their questions into chat, and we will follow up with Patrick and see if we can get answers to any questions we can't cover during the Q&A. So, Wes, could you give instructions for how people can ask questions on the phone line?
Certainly, the floor is open for your questions. If you have a question or comment, please press 7 on your telephone keypad.
And while we wait, Patrick, I'm glad that you made the point of addressing the comments from the CMS administrator, because I have had several questions from providers thinking that meant that this was the last year of meaningful use.
Yeah, when I saw this, even internally, we were like, oh, that's interesting. But we knew that because we had this 2-year look-back period, we knew by law that the meaningful use payment adjustments were sunsetting, that this year was still the performance year, and we knew that in all likelihood, even though it hasn't been completely finalized, that 2017 will most likely be the first performance year for the new MIPS program, which will have an EHR component to it. But yeah, I mean, we're still, by law, we have to implement the payment adjustments and the incentives through December 31st, 2018. So just want to make sure that everyone knows that meaningful use is still the game to play in 2016.
Wes, do we have any questions?
At this time, there are no questions.
I'd like to make a few comments. One is back to the discussion and the administrator's comments. It is really about a very high-level description of where the healthcare industry is moving in the context of using health information technology. It's not just a separate program for reporting and either an incentive or a penalty. And his reference was really to the much broader use and what meaningful use really means in healthcare delivery and quality and safety. I'd also like to comment, going back several slides, Patrick talked about resource use and cost and quality. And in the MIPS program, if you go back to the slide that lists the clinical improvement practices that you'll be required to use, you'll see that in the first year of MIPS, resource use is looked at only at 10%, but within 4 years, I believe it's up to 30%. So if you're not accessing your quality, your QRUR reports now, this is the year to start looking at those reports in the context of resource use, quality, and cost, and how you fare next to your peers. There's several different areas that you can look at and glean some of that information. If you have difficulty, let us know. I believe last year we did a few webinars specific to the QRUR report, and I believe we did one for VHQC. But if there's any questions, please feel free. Don't ignore those QRUR reports.
Dr. Connors, I'm very glad that you brought that up. That is something that we have encouraged our providers to look at, the 2014 QRUR, so your 2014 performance in PQRS and the corresponding cost data are available, and VHQC staff would be happy to help you figure out how to get it and then how to interpret it once you have it. So please reach out to us if that is something that you want to spend some time sort of trying to understand and get to know, because as Dr. Connors mentioned, they're not going away and they will be a huge part of payment reform going forward, so it's important to understand those. Wes, do we have any questions on the line?
At this time, there are no questions over the telephone.
I do see that we have a question in chat. Pam Isabel would like to know if a group of physicians received their first payment in 2012, stage 1, and applied for, if they received this, I guess she's trying to, I think what she's trying to figure out is what stage would she be in if she did not report in if they started in 2011 and then they did not report in 2013 or 2014, what are they supposed to report for 2015?
Well, as I mentioned, it is one set of measures and objectives now. So there's no distinction between stage 1 and stage 2.
So it's really only if a provider if this was their first year, there would be some modifications, but otherwise it's all the same.
There might be a few modifications also if last year was their first year, because the way that the program was set up, when anyone jumped into the program, they got 2 years at stage 1, 2 years at stage 2, and then stage 3. Now, the deadline, the timelines were pushed back a little bit because we started stage 2 late. But if we were under the old program, you would be in stage 2 this year. But we're under the new program, the modified program, so it's the same 10 objectives for everybody.
Okay, great. Well, it is almost 1 o'clock. I do want to check and see if we have any last questions. Wes, does anyone have any questions on the phone line?
At this time, there are no questions over the telephone.
Okay. Well, I really want to thank Patrick and Dr. Connors for taking time to explain this very complicated stuff and making it more simple so that we can understand all the nuances related to PQRS, meaningful use, and the value modifier. I appreciate everybody's time today. We will be following up with the slides, and you have our contact information. Please let us know if there are specific questions that you'd like Patrick to address, and we will follow up with him and get back to you. Thank you very much for your time today.
Thank you. This concludes today's teleconference. We appreciate your participation. You may now disconnect your line at this time.